Welcome back to AGIC, Science into Practice, the podcast where we talk about outbreaks so you don't have to live through them. I'm Nicki.
And I'm Jess. Today we're talking about measles, one of those viruses that enters the building and immediately acts like it owns the place.
Ugh, absolutely. And it's especially jarring when measles is something most of us were trained on academically, but filed away as historical. And we didn't expect to see it again, or not like this at least.
The science around measles hasn't changed. The virus hasn't changed, but the context absolutely has.
Yeah, and when population immunity drops, hospitals are the ones that are left managing all the consequences.
Absolutely. So today we're joined by the authors of Infection Prevention Processes Implemented at a Children's Hospital During a Community Measles Outbreak 2025, who walk through what it looks like when a hospital goes from, we haven't seen measles in 20 years, to full incident command.
Woo! Okay, well, first up, we'll have Lacey Kovar. She is the senior infection preventionist at Covenant Children's Hospital. Lacey brings a public health background to hospital infection prevention. She started her career as an acute disease epidemiologist investigating outbreaks, which becomes incredibly relevant very quickly in a situation like this.
Yeah, she has 9 years of experience across inpatient and ambulatory settings and is board certified in infection prevention. When measles showed up, she was already thinking in terms of transmission, population risk, and containment.
Wowzas, good to have her. And we are also joined by Chris Gould, Senior Director of Environment of Care and Facilities Engineering for the Texas-New Mexico region. Chris oversees facilities operations across multiple hospitals, and when airborne isolation capacity becomes the bottleneck, that role is suddenly front and center.
Chris's background includes custom metal fabrication, home building, and service in the U.S. Army Corps of Engineers, which may explain how an outdoor measles screening shed became both a thing and a solution.
Oh, interesting. Can't wait to dive into that. And finally, we have Christie Vandegrift. She's a senior manager of infection prevention at Covenant Health. Christie is a nurse with over 20 years of hospital experience and 17 years in infection prevention, overseeing IPC efforts across West Texas, surrounding communities, and coordinating closely with public health throughout this outbreak. Okay, so let's rewind to January 24th, 2025. You get a call about a suspected measles case. No recent institutional experience, no outbreak officially declared yet. And that's definitely not the call that anybody wants to take. So at that moment, what were you thinking? Were you thinking this could be nothing? Or were you like, we need to get ready? Lacey, let's hand that off to you.
So I was thinking, this is a typical Friday. We're going to get a call about something that is as important as measles. And now we have to decide, is this actually measles or not? So when our nurse manager first called me, she said, hey, we think we have a patient with measles on the floor. And at first, I didn't believe her because we have never had a measles patient ever at our hospital, and we hadn't had one in our community. So I asked her, okay, right. I was like, well, what are the symptoms? And so she, of course, described classic textbook symptoms of measles. And I told her, well, either they Googled measles and they're doing a really good job of describing those symptoms, or we actually have a patient with measles. So we waited for the provider because at that point, it was the family that told us they thought they had measles. And they actually had told us there are other kids in our community that are sick with the same type of rash. So we waited for a provider to actually assess the patient, and they came back and said, yeah, I think it's actually measles. So, of course, we called our health department, and at first we thought, well, maybe it'll just be this one. Granted, the family had already told us there were other kids in the community that had a similar rash. So we were kind of hoping for the best, but that happened on a Friday, and by Sunday we had our next patient. And they also had the same symptoms of measles. And so we knew that this was probably going to be a lot bigger than what we realized. So that's kind of how it progressed.
Measles definitely has a way of turning let's wait and see into why are we activating incident command very quickly. And you activated incident command on January 31st. That was a really big move. Who needed to be at the table early?
Okay, I'll take this one. This is Christie. Well, we decided to, do our first notifications when we had that first patient. So our leadership and, like Lacey said, public health. We didn't want anybody to be like surprised, though we were still kind of like iffy about it. But then we had those, we had another case present, and just knowing that this community, they're a special population, and they're not in Lubbock County, they're in Gaines County, but we know that these folks seek care at all of our Covenant facilities. And so the likelihood of them coming here was there. And then knowing that there were others in the community, it really got us, a little bit nervous. And we didn't know that the result of our first kiddo we had that was going to take us so long to get that result. And then we had another patient. And we started thinking about like the overarching, key thing is to prevent exposure. So we know that it's airborne, it's highly contagious, it can be infectious 4 days before that rash appears. And so we were thinking it could be easily dismissed by other providers, that we really needed to start talking about this. We took so if a patient is coming into one of our buildings, we kind of looked at that patient. They're going to enter, they're going to come into a waiting room, they're going to go to the desk, get triaged, just really that pathway of that patient coming. So that's what started us thinking who all we needed to involve in our command center. So entering our building, how are we going to alert people? We were thinking, okay, we're going to put up some signage that says, something like, what are the symptoms? Please don't enter, put on a mask before you enter. You can need people to help you decide like what that needs to say, what pictures need to be on it. And one of our unique challenges was that the language in this particular community was their first language was not English, maybe not even their second language. So we had to even involve interpreters, and that not be the case in many other scenarios. But that's our uniqueness. So you got to kind of think outside the box of maybe what that unique person is. So we had to involve interpreters at this point. And then, coming in, we're thinking, who can help us make those signs, make them appropriate, make them, meet all of the qualifications that we, have to have. And so we got our public relations involved. Then obviously nursing, who were pretty much involved in the conversation from the beginning because they're the ones that alerted us for that. But really, what do they need to know? Who can work on that? So we started working on some tools of what we're going to do for screening and some things like that. So you've got to have your nursing. And then thinking about these folks that, these children that have already been in our hospital, we're looking at some exposures. What are we going to do? What's our exposure response? And so I was thinking, well, we need to employ health. We need to know, if our staff are immune or not. And then what about, fit testing? The N95s, does everybody have an appropriate mask? Do they know what size they need to wear? And so we involved a caregiver health. We call them caregivers, but you're basically employee health. And then we needed the public health liaison who's going to, keep this communication with our public health, because we kind of needed to know what was going on in another county. So, we're talking to our county health departments and, really kind of keeping this. And that pretty much fell on in the infection preventionists, maintaining that relationship with the public health. And then we even thought, supply chain. There are people that are providing our masks, providing our isolation carts and everything that goes along with that. We needed them to be involved. And then, environmental safety and our facility engineering. This is why we got Chris on. It's all about what's in the air. and what stays in the air, and how is our air supplied, and how is our air taken away. All of these things, you really have to have somebody that knows your building inside and out. And then the last thing we did include were our outpatient, like we have several clinics and things, and we really needed them to know because these patients can enter those buildings as well. And so we put them on our command center to keep them updated and help them with their unique needs.
So follow-up question to that is, did the COVID-19 pandemic, and I know we're done talking about COVID, but did the COVID-19 pandemic provide you with any sort of preparation for something like this? Were there things that you drew from that situation that you thought were useful in this situation as well?
Yes.
So there was some good that came out of that.
And I could add, just because at the Children's Hospital, we didn't have quite as many COVID patients as the adult campus did. So yes, we did prepare. We were part of the Incident Command Center, but we did not have the same influx. So this was very different. I was telling everyone, like, our COVID, because this was our influx of infectious patients compared to what we actually had during COVID. Like, it felt a little more manageable. However, we utilized the same tools and resources. So it was different, but we also were able to fall back on what we had. And Christy, I don't know if you had something to add.
No, I was just going to continue on, kind of with the command center. When we were experiencing COVID in that place, that command center where everybody could stay on the same page, bring questions, then report back our solutions, things like that. It was just so, important that we had that group. And I think that a lot of us that experienced this in COVID and now we're doing measles, that we really appreciated having that group. And everybody, or most everybody, knew that importance of, if I'm being asked to join a command center, they need my input. And so it was well received.
And a lot of people working in healthcare today have never actually seen a measles case, which is a result of decades of prevention. That's not a failure. That's supposed to be a positive, but it also means rapid education matters. And some folks were probably refreshing themselves on what measles actually looks like in real time, like you said earlier, had they gone to Dr. Google. So you have a one-page education tool, and you have an identify, isolate, and inform algorithm. And those were incredibly practical, because in an outbreak, nobody has time or the mental span to read a novel. So can you talk about how those materials were developed and deployed?
I sure can. So for the identify, isolate, inform, that was something at least that we kind of already had formatted, because obviously we've all had to have that for Ebola or high consequence infectious diseases. So we kind of utilized what that looked like and then applied what was happening with measles. And so we quickly manipulated that because, again, we'd already seen 2 patients, third one's coming, and we need that information for our ED so that they have that and they can quickly look through it. And we just formatted it, put those quick questions, but then also we had to talk to our ED, like, what's realistically happening? What are y'all seeing that we have questions about that maybe would help? Because the document that we put in our publication was finalized in March. However, this all started in January. So over time, like, we had to tweak it and make small adjustments to it, because some things, we weren't thinking about. Or visitors. Can we have visitors? Are y'all limiting visitors? What are we doing with visitors? And then it goes back to that incident command where we talked about that. Like, do we need to limit visitors? We had to look at our population. We had to look at, like, this is a large population that's unvaccinated. And so there is a potential that if we just allow visitors like we normally do, we could have someone incubating and then walking through our hospital and potentially exposing other people. And so we made that hard decision that we should probably limit visitors and keep those same visitors so that we kind of know, like, okay, they've been in and out. Let us know if you develop symptoms, things like that. And so That was where our identify, isolate, inform came from. And then we had to have 2 versions. So we have our pediatric ED department, and then we have an OB ED department, and they are located at 2 different spaces, and they have different capabilities. And so our women's OB does not have a negative pressure air room in the OBED. So we had to work with them on, okay, if we had someone present, what do we do? And so we kind of worked through their identify, isolate, inform. And then for pediatrics, we do have an isolation room, but unfortunately we only have 1. And so there were situations where when it first began, they had 3 patients show up that were suspected of measles. And we only have 1 airborne isolation room. So what do you do? Where do you put those patients? So that question came up, like, what if I have someone show up? Where do I put them? I don't know what to do. And so that's why we added that information. And then everyone just had general questions about measles. They just wanted to know background information. They wanted to know incubation period. They wanted to know, well, what do we do in this situation? And so for all staff, that's why we created that general FAQ. We used those CDC guidelines. At the time, they were from 2019. They've been updated since then, but we used those 2019 guidelines, and then we just quickly put it within that document so people could quickly look at it and review it. And we've talked about it on the units. We took it down there. We talked to the nursing about it, did education with managers. They were pushing out education at their safety huddles. We had a town hall for the whole hospital so that if people wanted to ask questions, they'd be able to ask questions. We presented that same information. We added all of our measles information to a SharePoint. So that way, if staff needed to get on the SharePoint, that they could. However, sometimes people don't want to have to go find a SharePoint. So I created folders for each of the units, and I printed out what was applicable to them and what they could utilize. And that way it was a red folder that I just gave everybody, and that way they could grab it. They could look at what they needed to find, and they would easily have it available for them. Because it was easier that way. I created my own folder for me so I could quickly look up things when I was being asked.
Well, one of the things that I really loved was the concept of the roving N95 fit testing, because outbreaks have a way of revealing every gap you didn't know you had. And I know from my experience during COVID, again, bringing back the COVID, was that we did identify that we didn't have the best fit testing program. So how did you operationalize this roving fit testing, and what surprised you about the staff response?
Well, when we, early on, we knew that we needed to involve our employee health and, that they would need to be looking at the staff immune status for, the children's hospital. And then also, exposures, we were, making sure that we had our N95 masks, both sizes, and everybody knew what size they wore. And when they were asked, when we were asked to see, is there anybody, that is due for their fit testing, it was very surprising to find out that most of the employees, most of the staff needed to have that done. And going back to COVID, even then was, we were kind of on a let's conserve our PPE, including our masks. And so we had stopped doing a lot of fit testing because of the number of masks that it took to do that. And, with the premise that we would start back up. And so that really never really got going again after, and then it just kind of became, I guess, we became complacent on that. And so that was a big thing. And so we're like, how are we going to get the masses, done, fit tested? So at first we looked at the, those that were at most risk, the patient facing in our points of entry. And we said, hey, you need to go over to employee health and get fit tested. And that just seemed to be our employee health is in a different building. So it really kind of seemed to be, something that they didn't want to do. It took time, took planning. We're going to go before work or after work or, and we wanted them to do it quickly. And so it was decided that we will, we're going to bring fit testing to the hospital. and they would set up in the classroom and be there for certain hours. It would announced overhead where they could go and get their fit testing done. And then if that didn't work, they would go and seek to see if there were people working on the unit that needed to be fit tested. I know that also kind of what sprung off from that was that they would train some other people to be able to do the fit testing that were competent in doing that. And so we've got a lot, other folks that could do that and be on site. I think one of the other surprising things is in this, era where we're living right now, there's a lot of weight loss going on, some really dramatic weight loss, and that changes the fit. And so there were some people that did wear the regular mask and now wear the small mask. Or you would have, some men with some facial hair that the fit testing, some of the men and their facial hair, it changed the way they needed to, apply their mask or where they needed to tighten it. And some, so anyway, just some incidental things that we learned through that we should take into consideration, and make sure that we have the appropriate N95s available to our staff.
It's all about being resourceful, really. And speaking of resources, sometimes facilities is the hidden one in the hospital. So, Chris, I'm bringing you into the convo here. So we have to talk about the screening shed. And this is where the response shifts from like a standard IPC playbook to true interdisciplinary problem solving. So you all had an outdoor screening shed with heating and cooling and windows and PPE, which is honestly sounds a lot nicer than my break room and probably a lot of people's break rooms. And so how did that idea come together, and what problem was it really solving?
Yeah, so we were sitting in the command center, and it's our executive leadership team and Lacey and myself, and we were trying to find a way that we could screen our patients outside. If you look back to the COVID days, we had the big tents, we had the things like that. We were concerned about what the look would look like for those that were coming into the hospital. There's a known outbreak in your community. You have this massive COVID era PTSD tent outside. We didn't want the look. We didn't want people to be afraid or to be scared. So I told them, let me build you a she shed, is what we called it. And I sat over here for a couple of days at our warehouse, and we built a she shed. So me and my wife got together, and it was a great family building time together. We had a wonderful event. But no, we wanted to make sure that our staff were comfortable and that they could have windows accessible to watch our patients and folks walking up to the ED. Of course, it had to have, with Lacey in the background, our cleanable surfaces. So it's got 100% solid wall surfaces on the inside that are impervious. We wanted to make sure that our staff were comfortable. And of course, with us keeping PPE in it, making sure that PPE could last, whether this was going to be a few day issue early in the spring, or if it was going to be a summer event. I didn't want our staff standing outside in a building that was 100 degrees. So we bring in portable air conditioners. We do what facilities do. So that's how the she shed came together. It was a great impact. We painted the colors of the hospital, made it try to look lively and festival for our children's folks, and plastered signs all over the outsides of it. This is our check-in stations, directed people that direction.
I love this. I hope they got to keep the she shed.
We do. Actually, it is still here. So we decided, just like with our COVID days, that it would go to our stock of inventory, right? That if we ever had an outbreak in the future in the community or anything like that, we could revive the shed and it could come back out.
That's fantastic. My dream is having my own she shed, but I don't know that that's going to happen.
Hey, looks like Chris needs to
let's talk after
work
this.
in our backyard.
So you did have an impact. It sounds like exposures dropped significantly after moving the screening outside. So that's a huge impact, especially for staff working within the buildings. And you also expanded from 10 to 26 negative pressure rooms. That's not a small lift. How was that accomplished? And how did staff manage room turnover and air changes, validation at that scale? Like, how did that all work?
So one of the greatest things that we learned during COVID was what is our building's limitations and its capabilities. Okay. We had to learn a lot on the fly in COVID. So we just re-implemented the exact same processes that we had already mastered during that breakout. So with us having multiple hospitals, we didn't have a whole lot of, COVID at Children's, but we did at our adult hospital. So we brought what we did there. We have 125, HEPA quality negative air pressure fans. We, acquired these things during the COVID outbreaks. So we had resources. That's number one. You got to look at what your resources are and what your limitations are. Lacey and I would review every single room, and I would do the mathematical equations on what is going to turn this room into a true negative pressure room. And then, of course, you don't want to just exhaust air outside. You also want to HEPA filter that stuff, right? Anything greater than a MERV 17 quality filter is considered good, and we could return it or exhaust it. Luckily, we have an older building that the windows are still operable if you make them that way. So we were able to exhaust to the outside. So we could expand up to 26 rooms if we needed to. We were ready to expand up to 100 additional rooms. The only areas that we saw that we would have problems are those in like our ED Lacey spoke about. We don't have any windows in those areas. So we had 20 negative pressure fans that have UV lights in them and a HEPA fan or a HEPA filter in it. We set those in corridors to build breakaways. So therefore, as we had, folks coming in one door, we were keeping those that had already been screened or seen going past our fans. So therefore, we could capture all of that data. NIOSH came out. It was awesome. The state helped us with that piece of it. And we walked around and we looked at every single one of these room setups, looked at how we were doing things. Even though we didn't have any rooms, we were at such a great negative pressure that we were providing 99% fresh, or clean air for those patients. So just knowing your building's limitations, you've got to know what your capabilities are. What are the loopholes and what do you have downstream that you need to change in a rapid, and then being able to bring that stuff forward and do it.
What a logistical challenge and a great job at just pulling it all together.
Yeah, and I think just to everything that the three of you have spoken to so far, the COVID crisis was not wasted. There were a lot of learnings that it sounds like you put into effect in this measles situation as well. So thank goodness for that, at least.
Yeah, Jess, if you go back and you look when we first had COVID, it was a struggle. People would spend hours trying to resolve how to get a room changed over. We got it down to an art. It really is. So somebody would reach out and say, we need another negative pressure room, and my team would have that room negative built design in 15 minutes. And I had that availability 24 hours a day, 7 days a week. And fact verified, we had room pressure monitors. We had all of these things, but that's the fortitude. Don't forget what you've already faced. Bring that stuff forward. It's not wasteful. It may need to be shifted, but it's not wasteful.
Yeah, it's incredible to see all the work you guys did. And I want to pause here and focus on the outcome. So nearly 100 patients were evaluated and more than 800 patients were hospitalized concurrently. So with 0 secondary measles cases linked to hospital exposure, that's amazing. That does not happen by accident. And I wonder what you think were the most critical controls that made that difference.
Honestly, to start it, one of the most critical things was screening our patients before they came into the hospital, to making sure we didn't have any secondary exposures, and to make sure that we didn't have anybody potentially coming into the hospital that could have spread it, even visitors. Everyone got screened when they came in. We did not want to have any risk. So we are a women and children's hospital, and then on the other side that is connected to us, it is a cancer center. So we have some really high-risk populations that we did not want to expose. Also following strict isolation with our visitors and strict isolation with our patients. So making sure when we had a patient come in, we're placing them in our negative pressure rooms, making sure we have negative pressure rooms available, making sure everybody's wearing the proper PPE, we're answering questions, we're leaving the rooms empty for the amount of time that they need to, because that was something that people weren't as familiar with. You don't normally have to do that for all of our other organisms we isolate for during respiratory season. So making sure they realize, like, hey, in these rooms, we have to leave it empty for 2 hours. However, we followed the CDC air changes guidelines, and we were able to modify that for some of our negative pressure rooms. Because at one point we had 10 measles patients on our pediatric floor. And so, we had to use our resources and we had to use the guidelines effectively. And so that really helped us making sure that we were not potentially exposing anyone. And then Chris adding those quick negative pressure rooms. Like, we have on our PD floor 2 negative pressure rooms. And like I said, at one point we had 10 patients. So it was really important making sure that we had those tools in place. And I really think that that's what made us successful.
Just add one thing about really communication to the staff that were taking care of the patients, that they truly felt like they were informed and that they were supported, and any concerns that they had went to the right channels and were resolved. One in particular, like our environmental services folks that cleaned the rooms, they wanted to know the science about measles and what the risks were and what exactly we were doing to protect them. And when they got those answers, it was really good, very significant, the communication.
Yeah, and your collaboration with public health really stands out in the paper as well. What did that partnership look like in practice, especially around the testing, exposure management, and the PEP decisions?
So the most integral part was for sure the lab testing. So like Christie said, when we first started, when we had our first patient, it happened on a Friday. The state health department doesn't do testing over the weekend. So we would have had to wait till Monday to get approval to get the specimen out. Our lab thought our turnaround time would have been, I think, about 5 days. So we were like, okay, we will probably get that result back by next week. That actually took longer than expected. It took over a week before we actually got a lab result back. So when we had our second patient on that Sunday, the health department was able to get that approval for that testing on Monday, and we had a result back by Wednesday. So we were getting results back within 48 hours, unless it was like on a weekend. So it was really important, and having that help. And then they added testing to our LRN lab, and we were getting results back within 24 hours. And so that was integral, and especially recommending post-exposure prophylaxis for anyone that was potentially exposed. So having that partnership with the lab, that's number one, and them working with us. And then following up on our post-exposure prophylaxis recommendations. So when we initially had this start, we reached out to our health department and asked, what are the specific guidelines that you guys recommend for post-exposure prophylaxis? And then they provided that to us, and that is what the document we worked off of and working with them. And then later on, so if we did have any potential exposures, they would receive like IgIM here at the hospital. And then we were trying to, because we didn't want to have an influx of patients coming into our ER to get like the measles vaccine for MMR for their post-exposure prophylaxis. So trying to work with our physicians in the community, but also working with public health, because they had set up vaccination clinics. So they were able to go either to the vaccination clinic within their community, because not everybody lives in our town and they would have had to travel here. So that helped. And then also we had a local one here as well, and they were willing to help at that local. So that, again, we didn't have an influx of patients to our ED because we were already having a high number. And of course, this happened during respiratory season. So we were already seeing a lot of patients anyways. And then the last one is for our exposure management. So for our post-exposure prophylaxis, we had to work with the health department because we did not have access to the MTRAC system, which is where you could look up vaccination status for individuals that received it. The state tracks it. So we didn't have access to that. So we were having to work with our local public health department for any patients that were exposed so that they would look that up for us. And then they would let us know, like, hey, this person's had 2 MMRs. Hey, we don't have them in our system. And so based on that and the guidelines that they already provided for PEP, we would contact and notify of the potential exposure and the recommendation on what they should receive or if they need to receive anything at all, and then follow up from there. And then, just as Chris said, we had CDC come down and they looked at they were part of an EpiAid, and they were part of an EpiAid for this state. And they were really focused probably on Gaines County, but because of a lot of the patients were coming here to Lubbock and coming here to our hospitals, they offered to come out and, look at our infection prevention processes we put in place, look at our environmental processes we put in place. And so it was very helpful having them out here and looking at our different processes and really validating everything that we did. I mean, we had already put everything in place starting in January, February, and they were able to come out here probably at the end of March. And really, they were just validating what we had done, a few minor suggestions, but they really supported us. And it felt great hearing back from them and having that support.
Yeah. I mean, just from the facility side of it, I was completely relying on Lacey and her background. I have never had to look at a measles case in, my years of experiences or any of my backgrounds. So I needed her knowledge to tell me what I was facing and what do I need to do? How do I need to take a look at this? And taking her feedback and then taking a look at our, facilities infrastructure of what are those capabilities? What can we do to help Lacey meet this?
So if our listeners wanted to remember just a few things, really quick takeaway bites, what would they be? Chris, why don't you start us off on that? Or Christy, you know what? Let's talk about the incident command and teamwork. What's one little bite you would give us?
Just to include a rep from all of your departments that have that stakeholder role, and it's almost everybody in that. You need representation that, one person may have an idea that, you didn't think about. There's going to be something unique about your situation. So having all brains together is just our success, I think.
My thought is prepare for your influx of patients, know what your processes are going to be, and know about your population that's being impacted in this outbreak.
Preparation. And Chris, you wrap us up.
Absolutely. So from the facility side of it, the ability to make quick changes and think outside the box, utilize resources and things that you have used or faced in the past and from others.
Right. Well, don't wait until measles is in your building to figure out how your building actually works.
Indeed. Yeah, I really want to thank you guys for sharing this experience. It's scary and intimidating to an experienced IP or a new IP. So the paper really does give hospitals a practical roadmap. It's real. You're going over real constraints, real decisions, real teamwork.
And while we've had a few lighter moments today, the message is serious. Measles is highly contagious, resource intensive, and unforgiving of delays. And let's keep in mind that there are deaths associated with measles. For our listeners, check out the full article in the American Journal of Infection Control to see the algorithms and educational tools that we discussed.
Absolutely. And of course, since we talked about preparation and prevention, vaccinations are key. So thank you all very much for listening to Science into Practice. Stay safe, stay prepared. Maybe go take another look at your negative pressure rooms. And guys, that's a wrap.
Thank you for joining us today. We are Nicki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Althan and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.